Good evening, Dr. Khanna. Thanks for the opportunity, and I appreciate your commitment and your efforts for performing and conducting this conference in these tough time, COVID times, in spite of all the odds you're facing in Delhi. Congratulations, that shows your commitment for education. And COVID virus can make us want us to socially distance, but it can't isolate us socially. Still, such meetings will help us to exchange our ideas and thoughts, and such sort of things like. What is latest happening in US and all can be learned, and we can help our patients locally here. And what I was supposed to speak is something on this newer antiplatelet drug called ticagrelor. It's no more new, but it's a little more potent and almost near ideal antiplatelet drug. And in these COVID times, there could be more relevance of this molecule, which has more antiplatelet efficacy compared to older clopidogrel, because we do see some patients who have little more thrombotic tendencies. With stents, we have much better quality stents now. We hardly saw any stent thrombosis. The occasional stent thrombosis also noted in this COVID era, maybe because of endothelialitis, increased inflammation. It's very relevant for us to use more potent antiplatelet molecules in these COVID times. And coming back to the topic, medical management of ACS, should ticagrelor be brought from shelf to tray? That means that we should be using ticagrelor more common compared to the previously what we were using as clopidogrel. This brings best wishes from Apollo Group of Hospitals. What I would like to do in the coming 15 minutes or so, briefly take you through antiplatelet milestones and tell you the qualities of ideal antiplatelet drug and express the limitations of clopidogrel. This will be dealt in more detail in the subsequent talk. And the scientific evidence how the ticagrelor is becoming the drug of choice because of its characteristics of better antiplatelet efficacy as well as optimal bleeding, and then which drug can be preferred in which type, and then conclude. And then you see this evolution of antiplatelet drugs. When we were students, we had only ticlopidine which were being used. Now the clopidogrel came, and we thought that's a very good drug. Even now, we use it to very significant number of patients because the most important character of it is safety. It is actually a very safe drug to be used, and efficacy-wise also it was okay before. And we did notice some problems in some of these patients because of resistance and other things. That's how initially prasugrel came with Triton trial showing that it has better antiplatelet efficacy, but there was more bleeding. Then we are coming into the ticagrelor. Now we have a host of trials which are listed here and showing the efficacy of ticagrelor in various subsets of cardiovascular disease, which I will take you through. Then if you see why the most important action of ticagrelor, if you have to see the for rapid onset of action, which we have for clinicians and interventional cardiologists, is very useful to give this molecule immediately on table also sometimes when we plan for ad hoc procedures, because by the time heparin's effect is over, the antiplatelet efficacy would start. If you see what is the reason behind it, ticagrelor is a direct drug and there is no transformation required. It directly goes and attaches to the receptor. Whereas if you see clopidogrel, it has a two-phase, two times dependent oxidation, and prasugrel is one-time dependent oxidation mechanisms are required to make the prodrug to active drug. That's how there will be time delay with these older molecules, and ticagrelor has a faster onset of action because it is the active drug. If you have to see what is the ideal antiplatelet drug, we want the action to start immediately. We want a superior antiplatelet action. We want most of the platelets to be inhibited, and we do not want resistance to happening. We don't want the effect to vary from patient to patient. It works in some patient, doesn't work in some patient, leads to thrombosis. That's what occasionally we have noticed with the older drug. We don't want drug to drug interactions, and proven data MACE reduction across all patient groups. This is the strength of ticagrelor, I would say. Lot of subgroup patients is being studied, be it the acute coronary syndromes. Now it is also coming into chronic stable angina type of subsets of patients, and especially post PCI, you are coming with a lot of data. Proven mortality reduction. This is one of the very few drugs we have decreased the definite mortality data of reduction of mortality when you use this molecule. Obviously, we want lesser bleeding if possible. Obviously, bleeding cannot be as low as clopidogrel may be because of a little more potent antiplatelet effect. But I think it is a balanced action, and compared to prasugrel, it is much less bleeding rates. So that's how we clinicians are very comfortable using this molecule, which has potent antiplatelets but not too much of bleeding. If you have to see the comparison of the previous molecules to this, as this is reversible mechanism of action, and when you give this, when you have to offset this drug, also reverse can happen within 24 to 48 hours after discontinuation. So any patient, suppose If he has to go for CABG, actually it is slightly better compared to prasugrel and the clopidogrel, which needs to be given off for long duration of time. And if you see, the maximum inhibition of platelets happens, unlike clopidogrel, which happens with about 40% of platelets, and the variability is much, much less interpatient variability. These are some of the challenges of clopidogrel. As I mentioned before, there's a pro-drug, and it works in some, it doesn't work in some patients, and it also depends a lot on the genetics and inflammatory status of this patient. And more of it will be talked by the next subsequent speakers. Coming back to ticagrelor evidence, initially, it was started with Plateau trial, which is again these large trials which have come. 18,624 patients in ACS proven that it is proven superior to clopidogrel. Then we wanted to study the mechanism of action, onset and offset. I would also mention to it later. And then Plateau diabetes subgroup studied. Then NSTEMI was studied. Then the Pegasus trial again came with again large trial of 21,162. I will touch upon this, and TREAT and the THEMIS trial, by which now this ticagrelor is actually made approved even in chronic stable angina. Recently, US FDA approved depending upon that. European Society guidelines way back in 2017 itself said ticagrelor to be used only if there is other clopidogrel should be used only if there is a contraindication to ticagrelor. That is, ticagrelor is recommended as a drug of choice, and both in while loading as well as NSTEMI and non-stable angina patients. And then prasugrel either or ticagrelor was a recommendation. If you see, that's how with the data coming very strong, the clopidogrel usage is gradually going down, but still in significant number of patients it is being used, and the usage of ticagrelor is going up. About 36 to 40% of the population is being on this new molecule. If you see other important difference of action, apart from the faster onset, less of patient variability, is this is the mechanism of ticagrelor. It has an initial special effect, not only of antiplatelet action, which is ADP mediated with that receptor blockage, but this specifically also inhibits this adenosine receptor. Thereby, it prevents the adenosine from getting broken down. And this adenosine increase also leads to some of the favorable effects, like decrease of tissue damage and hypoxia, and decrease of various types of inflammatory injuries and other mechanisms of action, which is beneficial with adenosine. If you see here, this vasodilatation, endothelial progenitor cell migration, decreased ischemia, reperfusion, which happens, reperfusion injuries which happen in STEMI and ACS, and electrical conduction abnormalities becoming hampered, all that is additional advantage for adenosine apart from the standard antiplatelet effects which in this molecule has. And these are definitely proving the mortality benefit and reduction of events. Only thing is, we need to be careful. Like any other drug, we need to rule out contraindications, which are mentioned here. Little more risk of bleeding and usage of PPIs could be helpful. And other side effect which this adenosine, though it does a lot of good, does cause is mild dyspnea feeling in some patients, which could vary from 10 to 20%. But what is the reassuring is, if you continue to use this molecule, most of the times this dyspnea tends to go away usage. Coming to other efficacy evidence which you see, that is THEMIS trial. This is again a very important trial which is done in double-blind flash and ticagrelor in stable coronary artery disease patients and who had diabetes mellitus. So what they have studied is basically compared to placebo, when the ticagrelor group in this diabetic stable heart disease patients, the events were less, and of course there was slightly more increase in bleeding as expected. So this trial concluded that not only in ACS acute coronary syndrome patients, stable coronary artery disease with diabetes, which has more sticky platelets, with no previous history of MI, they didn't suffer MI or stroke before, then usage of ticagrelor benefited in decreasing the ischemic events even in the subgroup of patients. Then THEMIS PCI trial, some subgroup of patients, about 60% of that, who had a PCI done before, had more benefits compared to those group of patients which do not have history of PCI. So stable patients who had PCI done already had more benefits in decreasing the events composite endpoints as shown here compared to those without. Then if you see this, there is again, if you net clinical benefit, even with a little more increase in bleeding was studied, it had performed better. So that's how the recommendations later, US FDA, depending upon this trial, approved this molecule even for chronic usage. Maybe if you have bleeding tendency, you can go down to 60 milligrams BD. This is another trial which is being studied in the chronic usage of stroke patients, not only in coronary artery disease. In the prasugrel, you know that we can't use that if you have TIA or stroke. But this molecule is again, the strength of it you can be documented by this if the results come out. This is being studied in stroke patients. The large data of 13,000 patients is being planned for this. The results are not yet out. Pegasus TIMI 54 trial, this is the original older trial, what we were part of it, basically is studied ticagrelor significantly reduced the composite endpoints of death, MI, stroke compared to placebo. Obviously, from then onwards, we started using this molecule. We need to be a little more careful with a little more higher bleeding rates, but 60 milligrams BD, which was tested, was slightly lesser bleeding. So wherever you find that patients could have little more elderly patient bleeding is more common, you can take the help of little lower dose. Then now we know that aspirin was a cause of culprit for cause of bleeding, and then when we wanted to control and decrease the bleeding events, then whether this molecule alone without aspirin could it benefit? That's what is being studied. Tulai trial, which was published a year back, showed that decreasing after dual antiplatelet therapy, stopping after 3 months of PCI and continuing only ticagrelor later for 1 year, decreased bleeding by 44%. This is a significant benefit. And not only when we were bleeding was less, we were not surprised, but we also thought whether ischemic events could be more, but they were not different. So that's how this trial said that even if you have after 3 months of DAPT, you can continue this molecule alone. But what we clinicians need to understand is a single antiplatelet drug is fine, but we are continuing ticagrelor and not aspirin. Recently, some data with Onyx 1 trial also came that even usage of aspirin alone was also okay. But I want to express caution that if you have to use one molecule, it's better to stamp aspirin and give this molecule a little longer for more patient safety, not to have thrombosis of stents and things like that. The TICO trial is another trial which is again performed in Korea. They basically had again significantly less of events, NACE they calling, that is net adverse clinical benefits. With ischemic events less, bleedings could be more, but combinedly patients had much benefit in the ticagrelor arm, in which along with aspirin when it was used. TICO trial later, when after 3 months again, when monotherapy was given, patients did better with the ticagrelor monotherapy alone. What it found in this is surprisingly even the ischemic events were less in compared to the dual antiplatelet therapy group. So ticagrelor TICO trial concluded monotherapy could be an optimal strategy for reducing bleeding risk without increasing the risk of adverse events in patients with ACS who are treated with stents. So this is after the trials are okay, but any real world registries do have data. Again, the Swedish Heart Registry showed that even the real world, see large numbers of patients, clopidogrel 33,000 and ticagrelor 11,000 patients. The data was adjusted. This again significant reduction, about half of them, though this is not randomized, but less incidence of composite endpoints in the group in which ticagrelor was used compared to the clopidogrel group. Then the separate analysis of death, MI, and stroke here also showed each individual subsets also benefited significantly in this registry. So this registry, large real-world observational study, concluded saying that if ticagrelor usage could benefit and decrease the incidence of death, MI, stroke compared to clopidogrel. Then now that we have so much of strong data on ticagrelor, we will get a doubt as clinicians whether the patients who are on clopidogrel can we switch to ticagrelor. How to switch and all we learned more with this rapid onset and offset studies which we did. So basically, when a patient is put on ticagrelor, then immediate onset starts. There's no need to be worried that some period will be without antiplatelet effect. But on the other hand, if you reverse patients from ticagrelor to clopidogrel, you need to be more careful because then there could be some period of, because clopidogrel takes some time for it to mechanism to act. We need to be a little more careful by loading again with clopidogrel full dose. So the advantage with this, again, as mentioned, is superior antiplatelet effect, fast onset. When you want to stop it also, it can go with rapid offset. So the platelet inhibition, as seen here, when it's changed from clopidogrel to ticagrelor, it doubles. And reverse could happen when you want to shift it down. So that's how we became confident that even the chronic therapy, if you want to switch patients from ticagrelor to clopidogrel to ticagrelor, is also safer. But when the patient in day-to-day clinical practice, when the patient is doing fine, we tend to continue clopidogrel also. But when our patient is getting into trouble with recurrent events, that is, I think, those are the subsets of patients who would benefit most by switching from clopidogrel to ticagrelor. This is another study, which is Electra study, which is said basically to study the pharmacodynamics and pharmacokinetics to study of 60 milligrams BD, because nowadays we are coming with the data of 60 milligrams BD is also safe. Then they wanted to study the platelet inhibitions and showed that both 60 milligrams and 90 milligrams performed okay, having similar inhibition. So that's why if you are worried about platelet, where some patients bleeding could happen, you can take the help of 60 milligrams BD. So thus we now know that ticagrelor in chronic therapy usage post PCI and CABG, that's a drug of choice. Medical management of ACS, we are using it. We were initially worried to use it thrombolysis. I think now we have data with the TREAT trial and others showed that after thrombolysis also this can be used. And this has anyway documented itself in ACS and long-term therapy. It's proven superior to clopidogrel. And the other, we interventional cardiologists were very happy to note the decreased incidence of stent thrombosis, which could be again a little more in this COVID era. It is better to use this molecule after the PCI. The 80 milligrams loading dose is given, followed by 90 milligrams twice daily. And then 60 milligrams could be used in long term if we are continuing this for about 3 years. Switching actually from clopidogrel to ticagrelor could be beneficial in some patients, which I have mentioned. Then administration of ticagrelor, one word of caution is we already know about it, but we shouldn't be using full dose of aspirin like with clopidogrel. The maximum dose of aspirin which is permitted is to be 100. We generally use 75 milligrams of aspirin because the higher doses when it is combined cause more bleeding. That's how patients were having trouble. So this is very important for us to understand that with clopidogrel, with ticagrelor, aspirin 75 only to be used. And if a patient misses a dose, it shouldn't be a trouble. He can take the next dose. And the other beauty of this molecule is if you want to go for surgery, again, 3 to 5 days, it could be okay compared to prasugrel, which has more longer effects. And obviously, you can't give both drugs together in enthusiasm to give patients more benefit. Only one of it has to be given. And it is beneficial even in patients with prior stroke, TIA, and weight being less, which were contraindications for prasugrel. So take-home messages, ticagrelor has superior antiplatelet efficacy, rapid and sustained antiplatelet effect over clopidogrel, proven in many trials. That's how the significant reduction, entire spectrum of ACS, be it with STEMI, NSTEMI, and now we have data coming up with the chronic stable angina patients in diabetes, also showing significant benefits of ticagrelor. Ticagrelor is a drug which reduces mortality, not only the events, and it also has additional benefits of decreasing reperfusion injuries and improving the microvascular flow with adenosine-mediated mechanisms, and it is documented to decrease stent thrombosis. And the other beauty is it can be given across all age groups, all weights, and even with strokes and TIA, we are going to further study this molecule exclusively in stroke patients. So with this proven real-world safety of 1.5 lakh patients, this is recommended by all global guidelines, and this has become the drug of choice probably in ACS and even in chronic stable angina patients. I would like to take your attention to this. I also wanted to give this COVID challenge to cardiologists. Basically, we have free time to convert this to productive time. Please don't waste your time if you are free from cases. Either you learn new skills or new knowledge or publish like what they do in West. And then if not, we wish all of you could use this time to yoga, meditate, become healthier and fitter. And please join us in the next month for this meeting. Thank you very much for patient hearing.
Thank you, Sreenivas. That's been great. And the next speaker would be Dr. Sunip Banerjee, and he's going to be speaking on clopidogrel resistance, reality or fiction. I would request Dr. Jack Tan, who is chairing this session, to actually take over take over the entire session, and request Dr. Sunip to come and take forward the activities of this session and make sure that people stay in time.
Khanna, you're doing such a great job. Maybe you should continue. We love to have you for this session as well. I think we should just continue.
Okay.